So I would like to invite up Kirsten Barlow, if I can. Kirsten is the Vice President of Policy at the California Hospital Association, and she manages our behavioral health issues, but more importantly, she's an expert in this area with prior experience at the Behavioral Health Directors Association, working for the state. So Kirsten is such a great leader for us, and we're fortunate to have her here with us today. So Kirsten, if I can hand it over to you, please.
So Carmela did a fantastic job of really laying the groundwork for what you all are, managing right now, and behavioral health clearly being one of those major challenges. Even before the pandemic, we really saw some alarming trends in not only youth, but really across the lifespan. More and more folks feeling isolated, less connected. And you add that on top of what we already know in many cases to be a genetic predisposition sometimes to behavioral health conditions. And so we're lucky to have 3 experts here today to talk to us about how we can address these challenges across the lifespan. Melissa Stafford-Jones works for the California Health and Human Services Agency in what I believe is a brand new position. This administration, Governor Newsom, has obviously not only infused many billions of dollars to help us better address behavioral health in California, but also hired individual leaders who are really a part of the Newsom team to really shine a light and push an agenda specifically on behavioral health. And Melissa's role is to oversee the Children and Youth Behavioral Health Initiative, which she'll be describing for us this morning. Marshall Moncrief will also be talking with you. He is the CEO of OC Mind, right? Mind OC. Many of you have probably heard about the Orange County Be Well model, which a number of years ago really has helped demonstrate what can be achieved when everyone comes together in a community rather than sort of trying to figure out whose job it is to solve these big, huge problems, but instead really come at it from a we're all in this together standpoint, and he'll be talking about that model. And then from Stanford University, we have Dr. Daniel Kim, and he'll be talking about sort of the other end of the spectrum. Our aging population, I believe, is the largest growing population of Californians and in many other states as well. So he'll be talking with us not just about that challenge, but some of the models that we can use to try to build on to address that growing challenge of aging Californians. So first, let's start with Melissa. I'll have you give her a round of applause to begin, and we'll have her talk about the children and youth behavioral health.
Thank you, Kirsten. Good morning, everyone. It's great to be with you. It is really nice to be in person. And I always appreciate being with hospitals early in my career. I actually had a chance to be a regional vice president with the Hospital Council of Northern and Central California. So it's good to be with fellow hospital folks. I'm going to spend just a couple of minutes giving you an overview of the Children and Youth Behavioral Health Initiative, and then I'll really look forward to some of the discussion and Q&A I'll have with my fellow panelists. As Kirsten said, our governor and our state legislature have made very significant investments in behavioral health, and I'll focus today particularly on our work related to children and youth. Okay, except I did it. So, and you heard Carmela share some of the statistics that I know we have all heard. I share some of them with you here. We know that actually the crisis of mental health for children and youth has been growing for over a decade. It was exacerbated during the pandemic, but it is not a new set of issues. We also know that from an equity standpoint, all of our children and youth from all communities, all backgrounds are facing struggles. But we also do know that some groups are disproportionately impacted by mental health challenges, and that they also face more structural barriers to access and well-being. And that is part of the underlying work that led to the Children and Youth Behavioral Health Initiative. I also think it's important to just remind ourselves that there is evidence, we do know there are things we can do to support improving mental health and well-being and behavioral health outcomes for our children and youth. So in August of this year, Governor Newsom announced the Master Plan for Kids' Mental Health. And as Kirsten mentioned a minute ago, talking actually about the work in Orange County, about sort of everyone coming together, in many ways that is also reflected in the governor's master plan for kids' mental health, which is the recognition that we need a whole child approach, an all of the above approach, and a collaborative cross-sector approach that addresses the silos in our systems that we know affect outcomes for children, youth, and families. And so the Children and Youth Behavioral Health Initiative that I'm going to focus on today is really at the core of the governor's master plan for kids' mental health, but it is also connected to other major state initiatives that influence the well-being of our children and youth. And that includes investments in education, particularly related to the community schools model, to the work that's happening that you all are very familiar with in Medi-Cal through CalAIM, both in terms of thinking about the quality of care for children, but also in terms of behavioral health, the investments in workforce that are happening both in healthcare, but also in school-based services for children and youth. So really this very comprehensive, multi-initiative, multi-sector approach that is embodied in the governor's master plan for kids' mental health. So what is the Children and Youth Behavioral Health Initiative that is at the core of that plan? It's a 5-year initiative that was created in 2021 and then added to in the 2022 budget, which I can say a little bit about some of the particular components that were added to the initiative. But the Children and Youth Behavioral Health Initiative is really about reimagining the ecosystem of services and supports for social emotional well-being and behavioral health of children and youth. There are several key aspects to it. One is that it is intentionally a systems change initiative. It's really thinking about what are some of the structural elements of the system that we have that get in the way of that well-being. And what we have consistently heard from our partners, and that's partners both in terms of youth and family with lived experience, but also our experts and partners with professional experience, is that the systems we have are deeply siloed, and that is a barrier to having the ecosystem we need to support well-being for our kids. And so breaking down those silos is really key. And the good news is, and it sounds like we're going to hear about this next, is there are incredible bright spot examples of where this is already happening. What we hear, though, is that they are challenging to scale and to sustain. And so that is part of our work of taking this systemic approach in the Children and Youth Behavioral Health Initiative. The Children and Youth Behavioral Health Initiative also is for all children and youth ages 0 to 25 in the state of California. And so there are many aspects of it that focus on a universal approach, but we also take a targeted approach because equity is at the center. And as I mentioned, we know some groups of youth are disproportionately impacted by mental health challenges, and we will need some distinct strategies to address those inequities. The initiative also covers the entire continuum of services. It is meant to encompass work from focusing on investments in well-being and prevention all the way to making sure that some of our children and youth with the most complex and intensive behavioral health needs, that those are better coordinated, more accessible. But the initiative does have a particular focus on prevention and well-being. One of the things we have also heard from our partners is that with our youth, we often do know that we could have intervened earlier. And that the sequelae of what happens for those youth, we could have had opportunities to intervene and coordinate and support that youth and family sooner. And that we need to take structural approaches to making that happen in a sustainable way. And so that is a key focus of the initiative. It's also really about building a much more youth-centered system. Carmela talked a bit about this. This is certainly a feature of the Children and Youth Behavioral Health Initiative, which is if we only continue to approach and do things the way we've already done them, we're highly unlikely to get radically different outcomes and really have a reimagined system. So one of the ways in which we are really looking to take a different approach is we have deeply engaged youth in the work of the Children and Youth Behavioral Health Initiative, and we are continuing to look for ways to do that on an ongoing basis in order to help us build a more youth-centered system. And I have some slides that I won't go through in detail, but I wanted to share them with you. We've been having a lot of conversations with youth in different kinds of focus groups and engagement sessions. And for example, one of the things youth have said to us is, please stop waiting until I'm in crisis to provide me with supports. They also know, for example, that their families need supports, that it's not just about supporting them, it's about supporting their families. So how do we really take what we are hearing from youth and embed it in the work of our systems? Collaboration and partnership is also at the center of the work of the Children and Youth Behavioral Health Initiative, both within Health and Human Services at the state level, but also with our partners and at the local level, but also across other sectors. Other than family and home, where is the place that youth spend the most time? School. Whether that's childcare, K through 12, higher education settings, it's school. So really focusing on where kids are, and that means how do we really build much stronger collaborations and partnerships between education and healthcare for this work. Also, I'll close here by noting that the other key piece here is a recognition that we're working to build a state-level framework, but that it will look different as it's implemented at the local level in different places. But we are really trying to capture what are the hallmarks of a reimagined ecosystem that can achieve these goals. We're actually working on a paper right now that I expect to be released in January, where I spoke with over 100 experts across the state and nation to help us say, hey, what would be different about how our system operates if we really had a more coordinated, equitable, youth-centered, prevention-oriented system? What would that take? And I will tell you what the paper says in short, because it's not going to surprise you. It absolutely requires a collective approach. That is the bottom line. We can't continue to operate in silos. We have to have a collective approach. There's a recognition that it's hard. It's not easy to do. The way we are set up collectively does not support that, right? The way government programs work, funding works, how data works, none of it is easy to do, but that is the critical shift, along with that youth and families have to be at the table, not just to be heard, but to be part of decision-making. So I've talked about most of these in terms of our approach. There is one that I want to, or two actually, that I want to focus on here that I didn't mention. One is this catalyst role of the Children and Youth Behavioral Health Initiative. In addition to the specific work we're doing in the Children and Youth Behavioral Health Initiative that I'll touch on in a moment, is really this role of thinking about how do we align our systems? What are the opportunities to coordinate? Cal HHS Secretary Galley, for example, spoke recently at the State Board of Education meeting on an agenda item they were having on the community schools model. So we're really digging in on what does it look like to integrate and collaborate and coordinate in the implementation of the Children and Youth Behavioral Health Initiative and major K through 12 education initiatives, and not just at the talk level, but at the practice level. I also want to note that a significant part of the work of the initiative relates to addressing public awareness and stigma. We have heard very much from youth that stigma remains a significant barrier to them getting the services and supports that they need, particularly early, and dealing with that issue of not waiting until they're in crisis. Clearly, there's still stigma amongst youth, but in particular, they talk about the challenges with their families and communities and how can we support addressing that. We have a very strong focus in equity on the initiative. These are the slides I wanted to include. I won't go through all of them, but I'm sure they're in the app. But this is what we have heard from youth that they want. They want a daily sense of connection. They want easy access to affordable services. They want a workforce that looks like them, speaks their language, comes from their community, and understands their experience. They want more resources and information to support them and their families in making their own decisions. They really are looking for safe spaces. This has been one of the most powerful findings from all the work that we have done with youth, is they really want to focus on their well-being, and they have talked about whether it's indoor spaces like a community center or outdoor spaces like a park, that is really critical to them and something that they are struggling to find in many communities. And I mentioned lastly, they also really explicitly recognized and lifted up that their families need support as well, that they know for their own well-being to be supported by their families need to be supported. So how are we actually doing any of this work and implementing these ideas and this vision for the Children and Youth Behavioral Health Initiative, and really this more equitable, coordinated, youth-centered, prevention-oriented ecosystem? So I think of these as our tools in the toolbox. When the Children and Youth Behavioral Health Initiative was created by the legislature and Governor Newsom and our secretary, It included 14 components, we call them work streams, that we are in the process of implementing. There's a very significant focus on workforce, and that's increasing the behavioral health workforce, increasing the diversity of the behavioral health workforce, and increasing the capacity of the workforce that works with kids to support their social and emotional well-being. So very significant focus on workforce. It also includes building out the infrastructure of that ecosystem. That includes bricks and mortar. You may be familiar with the Behavioral Health Continuum Infrastructure Program. One of the most recent rounds of that was specific to children and youth. And we'll be making announcements soon about those awards, but we know we actually have to grow the bricks and mortar service capacity for behavioral health, including for children and youth. But this also includes partnerships, resourcing partnerships and collaborations that don't exist today but that are critical, building out a virtual services program that includes e-consult so that we know our primary care physicians and pediatricians can get quick access to specialty consultation for behavioral health services. I already mentioned stigma, and last thing I'll mention on this slide is around the coverage architecture piece. One of the key engines for the ongoing work of this initiative is the development of a new fee schedule for school-linked behavioral health services. Department of Healthcare Services and Department of Managed Healthcare are developing this, and this will allow schools to bill and be reimbursed for services that are in this fee schedule from both Medi-Cal managed care plans as well as commercial health plans to really support that universal access to behavioral health services for our kids. I included these. We're in the midst of finalizing 5-year outcomes goals for the initiative and bringing an evaluation partner on board. And we have a range of initiatives both from a system and population level. And then lastly, I provided you with some links if you would like to learn more about the Children and Youth Behavioral Health Initiative. We do regular written updates. We do quarterly public webinars to answer questions and provide updates on our progress. And also each department that is implementing different of those components of the Children and Youth Behavioral Health Initiative provides regular updates to partners and stakeholders. And if you're particularly interested, for example, in the workforce components, you could be asked to get added to the mailing list for HCI on this topic and learn more. Thanks so much.
Thank you, Melissa. Why don't we go ahead and move on to Marshall Moncrief. I think because we have a lot of ground to cover in an hour to do it, we'll go ahead and hear from all 3 of our speakers, but jot down your questions and we'll try to take those at the end.
Okay, hi everybody. I'm going to move through relatively quickly, and it's good to see some of you again. I think I was here last in either 2018 or 19, so thank you, Demetrius, for having us from Orange County to share a little bit about what we're up to. Thank you, Carmela, for your talk and for your support of Be Well Orange County. In fact, after Carmela's talk, we decided to post a psychiatrist right outside the door if you need one. They'll be there here with a massage table. I'm pleased and privileged to share what we're doing in Orange County, and there's some good stuff going on, and I want to just put the caveat up there that we share this with massive humility because, as Melissa highlighted, I'm going to talk to you about a community-wide collaboration, and those are hard to do. We fall on our face every day and learn things every day, but it continues to advance, and we're really pleased to be able to share a little bit of it with you today. So, Be Well Orange County is a community-wide movement in the county of Orange, trying to create a world-class system of mental health care for everybody in the community, and it's going to take a whole community to do it. I may have shared this with you when we were here before, but for those of you that are new to it, the left-hand side of the slide is the way that the community experiences the non-system of mental health today in Orange County. And so all the little drifty flags, I'm not sure if you can read them, but they represent each of the sectors of our community. So the faith community is there, academia is there, the hospitals are there, the justice system is there. And if you ask a leader from any one of those sectors, what are your top 3 problems today? Every one of them will tell you mental health and substance use is in the top 3. In fact, in Carmela's tectonic slide, it was number 3 right in there. And so amidst the sectors who are all dealing with this problem through the narrow lens and resources of their own sector, or oftentimes more narrowly, their own organizations within a sector, amidst all of those efforts that are fragmented are the different people who struggle, and they all fall into categories. Some of them are insured, some of them are uninsured. If they're insured, some are publicly insured, some are commercially insured. Regardless of their coverage, their clinical needs vary from mild to moderate to severe. And that dynamic creates 1,000 different doors, and you gotta find the right key to get in the door to get care. So I get calls on my phone every day from people struggling who don't know where to go. So I'm not making this up. Every single day, it came through already today, which is, I won't use the name, but this is the chief of staff of a significant elected leader in the Orange County community, and she's texting because she's fearful her daughter is struggling with suicidal ideation. That's this morning right before coming up here to talk. And that's a really well-connected elected leader's kid. She didn't know where to go. So the dynamic of these fragmented efforts is that the crises in our community are increasing because we don't have a coordinated upstream approach like Melissa was just articulating. We've default built a system for law enforcement and EMS to respond to the crises. And so guess what? Our hospital ERs and our jails are filled with people struggling with mental health and substance use challenges because we've engineered the system that way. In Orange County last year, there was 50,000 ER admits for substance use and mental health related conditions. The vast majority of them don't need to be there. And for those of you that are doing the math on kind of average cost of an ER admit, times that by 50,000, and you're pushing about $100 million in poor care in the wrong place, the wrong time, and the whole thing. So we can do better. So what Be Well Orange County is trying to do is make the left side look, feel, and function like the right side. So can we get the whole community into a more coordinated ecosystem, just like the term Melissa was using, so that we build a unified system of care that wraps a hug around all of Orange County, regardless of their payer status or their clinical need, mild, moderate, or severe. So that's what we're trying to do. The way that we're doing that is we've organized ourselves across 6 result areas, sort of asking each other, if we were to advance a world-class system of care, and we're thinking with the end in mind, what areas would we have materially moved the needle? And those areas are stigma reduction, to your point, prevention and early intervention, closing the treatment gaps, and so there's a zillion little gaps across all those sectors, improving the crisis response system, for sure, there's fires out there and they're growing. We need to anchor this system with campuses of care that are comprehensive across mental health and substance use and available to anybody regardless of their insurance. And the last one is kind of a cross-stream effort, which is aligning policies, programs, and data. An example of that is the robust homeless services effort in Orange County has to be aligned with the mental health effort in Orange County. It's not always a one-for-one like-to-like, but the overlap is significant and they've got to meet up. In the middle is the little black circle that represents the nonprofit that I now work for. I was in the hospitals of Orange County for 20 years, and so I know your world pretty well. And we decided we needed a neutral nonprofit Switzerland system development engineer that had no other function on the earth except for bringing the community together around these 6 results and advancing the collaborative. And so that's what many of us are doing today. And the little gray dots surrounding those result areas are the organizations that currently do work in that space who we're getting coordinated around specific initiatives to do together. And it's simple in concept, and it's been challenging, but it's growing. And so we have 400-something organizations that are now tied into Be Well Orange County, a couple thousand people participating, some of them a little bit more peripheral, and some of them roll up their sleeves and are dead center helping to move this forward. And a lot of the initiatives you see are coming through different funding sources. We have a trauma-informed network of care underway, suicide prevention through MHSA dollars. DHCS is supporting us on expanding medication-assisted treatment for youth. So there's just dozens of initiatives where we have better coordinated than we had before, whole community across those sectors to do it together. Materially, especially for the hospitals, we are working on, oh, did I laser you guys? Sorry if I got someone in the eye on that thing. Wrong button. Materially for the hospitals, we're also building some tangible infrastructure that doesn't exist, hasn't existed in Orange County, and is now being built out. And the hospitals are critical leaders in building this stuff out. So under the Be Well umbrella, we want to build a navigation system. In Orange County, there's 18 different phone lines. All of them are well-intended. Nobody knows who to call for what, why, or when, so they call 911, and then they go to our ERs. So we need that on the front end. What's the Amazon of mental health that doesn't break down the 18 lines, but coordinates them under one digital access point? When I get home, my wife will have something from Amazon on the porch. I guarantee it. It will be a pair of shoes or a couch or something, and she will have done it by just one easy click. And so the system works. We can do the same thing for mental health. We just need better interoperability and partnerships to do it. It's not tech, it's politics and collaboration that'll make it happen. That needs to deploy for people in crisis a mobile response system. We're emulating shamelessly. So we've spent some time in Arizona. They've got a really good system there. They're meeting 80% of the crisis needs by way of a coordinated navigation front end, and then they have mobile vans that go out instead of law enforcement to meet people's needs in community. So we're taking that playbook and doing that right now. We're active in 5 cities, and we'll be active in 5 more in 23, and we're going out instead of law enforcement and EMS, stabilizing in community and avoiding people going to ERs. So we'll tell you a little bit about that in a minute. I know I'm talking fast because we want to keep the time for conversation. If we do that well, we'll put a material dent in the number of people that need facility-based care. And then if we stand up these campuses for those that do need facility-based care, and they can go there instead of an ER or a jail, now we're really starting to do something better for the human being struggling and something better for the system. All of that needs to be undergirded by a network of providers. The statistic that Carmela shared is a statistic I live in all the time with regards to the dearth of mental health providers that we're facing. The shortages in 2028 and beyond will be at 50% capacity of most behavioral health providers. So we need a whole community approach. We need to get more creative about what constitutes the definition of a provider in order to pull this off. And on the left side, you see this is the county, our Medicaid health plan, CalOptima. The hospitals are significant. Cities, private stakeholders, all of that is funneling through this little nonprofit who helps coordinate the public and private dollars and advance these strategic initiatives on behalf of the community. So that's what's happening in Be Well. I'll keep this short and quick, but just to give you a sense of this mobile program and then a sense of the campus, this is in support of law enforcement. This is in support of community. This is not adversarial to that. And the way it works is when a call comes in through the 911 or non-emergency system and goes to dispatch, today dispatch has 3 tools: a fire truck, an ambulance, and a police car. Again, why they show up at hospitals and ERs and mental health and substance use crisis, because those are the tools we're using, and that's where they can go. We're giving them a 4th tool. It looks exactly like that. It's a 2-person team. These are non-licensed clinicians who are trained specifically in this service, and they go out instead of law enforcement. They are a complement to the existing infrastructure of mobile services, but are making a material dent in some of the gaps that have been existing. Sometimes we are out in a park talking to someone who's struggling with homelessness, like the upper left. Sometimes, like the upper right, we're in somebody's living room. Sometimes we're just helping the person, giving them a bottle of water and building relationship. Sometimes we're putting them in the van and taking them to a clinic of their need. That could be the Be Well clinic, but it could also be the local FQHC. It could be an urgent care to get their wound checked out. It could be a lot of different things, trying for it not to be an ER or a jail. That's just the number of contacts that we've had. There is sort of a story about that, but that's a whole discussion. We'll leave it for later. It's a good thing. The average response time is pretty good, so we're responding in 13 minutes. Our county's CAT team is strained. This is not throwing a rock at them. That system is strained, and their response times are hours oftentimes. And so this, because it's at a local level, we're deploying at a city level, we can get there quickly, and we can spend a lot more time than law enforcement is able to spend. That's why we're able to stabilize the vast majority of the people in community. Most of the time, we don't need to co-respond. 66% of the time, we're not co-responding with law enforcement. That's increasing all the time as trust is built with this still young program. This one is the one that's important to me. 85% of the time, we're stabilizing people in community and not transporting to care. So this is not about scooping people up and taking them somewhere. It's because we have the time and resources and bandwidth to do that. And that's what's really helping alleviate pressures on our system, and in my mind is an example of health equity. One quick story, we're in Garden Grove. That's a large Vietnamese population. The team that we have in Garden Grove is many of them Vietnamese speaking and culturally grew up in the Vietnamese community. There was a homeless gentleman there, 75 years old, only Vietnamese speaking, mentally ill. And the law enforcement guys had done such a beautiful job of trying to engage him, but for a couple of years couldn't move the needle. Within 90 days, we had him housed. That speaks to health equity when somebody is of your culture and of your language and engaging you in a different way. About a little more than half are unhoused, but a decent amount of folks that we're connecting with are housed. And I'm going to skip past this. And then we have built our first building. I think when I was with you last, we had hopes and dreams of building this thing. We ended up pulling it off, and it's been open for a little over a year. Materially, this was built in a partnership that hasn't happened before in Orange County. And this, to me, is the most exciting part about it. Never before have those hospital partners, in many areas competitive, partnered together with our county or our health plan to do anything. I grew up at Hoag and Providence, so those are my two parents. It's been hard to watch them divorce, but they still come in the room and work on Be Well with hugs. And so all of those guys are on our board and actively involved and continue to move this thing forward. The building is made up of a full continuum of substance use treatment and mental health treatment. We have the community's first recovery station. We're really proud of it. I know for many of you guys it's kind of just getting to table stakes, but for us it's a new and important thing. We have our first crisis stabilization unit for adolescents, so they don't need to go to the ERs. That's linked to a detox and crisis residential and longer-term substance use and residential care for mental health. And so we've got 93 beds. They are often full, but the recovery station and the crisis unit functions on a 23-hour or less cycle, like many of you know. And we have a Sally port there far to the left, and that's what ambulances and law enforcement come in and drop off at all day long instead of the ER. And so somebody can get out of the car in a place that's dignified and quiet and respectable, and we can start stabilizing right out of the gate. I'm really feeling sensitive to time, so I'm going to wrap it up and sit down. But we've gone through a lot. What these slides show is we've learned a lot over the first year about the contractual structure and the regulations behind this thing, and we continue to make advancements, all for purposes of opening up access, improving the quality of care, and improving outcomes with transparency. And I'm happy to talk with any of you about that specific detail. And then we're on to our second campus in the city of Irvine. We're not going to tell anybody about this until after the elections, so we're a few days past. So we're building a big giant one in Irvine, and we're really happy about it. Thanks for letting me share.
Sure.
Okay.
Hopefully we'll have time for you to be able to tell everyone how to replicate exactly this in their own county, right? Yeah.
Yes.
All right, Dr. Kim, would you like to join us up here?
Good to know. Well, hello, everyone. It's an honor to be here, particularly because I have, till now, had the luxury of being primarily a clinician in the trenches who got to complain about the system and not have any responsibility to change the system. And it's really humbling to be in this room filled with folks who are dealing with this daunting task and see how many innovations and changes are hopefully in the near future. So I'm going to talk about a topic that's near and dear to my heart, which is how to better provide health services to older adults with serious mental illness. And I'll first review some goals. First, I'll review some of the numbers regarding older adults and mental illness.
You're taller than this.
I'm sorry. I'll review some of the unique challenges that are present in this population. I'll touch on some relatively novel interventions in geriatric mental health. And then I'll touch on some of the hurdles. And again, this is from the perspective of a clinician who doesn't know anything about the systems issues that you guys probably have been dealing with for some time. So this is a slide I always think of when I look in the mirror these days. You're getting old, I think to myself. But if it was just the wrinkles or the graying hair or the increased portliness that was present, I think most of us wouldn't really care about that. What's most frightening, I think, for us is the mental health changes, the cognitive changes, the CNS changes that are present as we get older. And it's a real thing because in many respects, cognitive change, dementia in particular, is a function of age. When you're at the age of 65, you have about a 2% chance of having a dementia, and that risk increases every 5 years afterward. So by the time that you're at the age of 85, there's about a 1 in 3 chance that you'll have a dementia, which is scary. And the reality is that we still don't have a good treatment for dementia. The monoclonal antibody treatments that have come out, as we all know, haven't been panning out. Beta amyloid may not be the culprit in dementia, as we all hope for many years. This is a slide I look at when I'm feeling down because it tells me that I'll always have job security. We know that the first baby boomers crossed the age of 65 in 2011, and we're now in the midst of what we call the silver tsunami. And by the time, by the year 2040, the number of people above that age is going to be about 80 million in the US alone. And it's not just the number of older adults that's concerning, it's the fact that the demographics of the US is shifting. In the year 2034, the number of people who are above the age of 65 are going to outnumber the number of people who are under the age of 18. And that's going to have significant impacts on our economy, our ability to provide health services to older adults. And we're already seeing some of this happening in Japan in particular, where that inflection point occurred in the year 1997. And from that point, the population has been shrinking, and their ability to provide health services to older adults has been increasingly strained. They're getting to the point where they're trying to provide services to older adults through robotics, which is, very innovative, but probably not ideal. And it's particularly challenging because the people above the age of 85 in particular are the highest utilizers of healthcare services. What's interesting, though, is that although the people who are who are older are the highest utilizers of healthcare services, they're not as likely to provide or to receive mental health service. In fact, they're often receiving inadequate or inappropriate care for their needs when compared to younger cohorts. What's interesting, though, is that even though they are receiving more healthcare services in general, the diagnosis of something like depression in particular is decreased. On average, about 15 to 20% of people in the older adult population are diagnosed with a depression, compared to 20 to 25% in younger adults. Which is not to say that this isn't a real issue, because as we can see from this slide, Although the rate of completed suicides among women is pretty flat, the rate of suicide among older men in particular goes up significantly. So there are real consequences to the underdiagnosis, under-evaluation of people with depression. And there's a lot of reasons why people who are older may be underdiagnosed with depression. There's something that we call the cohort effect that you may have heard of, which is basically describing how older adults, in many respects, come from a different culture, a different perspective on mental illness in particular. And they may not frame mental illness in the same way. And there's also, of course, the pronounced stigma that this particular population feels about mental illness and describing it or reporting it to family or their care providers. And consequently, it's underdiagnosed and undertreated. And it's challenging because there are good treatments for depression, particularly in older adults. But it's challenging because the reality is that it's not the same entity as in younger adults. In particular, depression in older adults is complicated by the fact that there are subtle cognitive changes that occur, likely related to subcortical vascular changes in the brain. And as a result, they struggle with not just the challenges of depression, but some challenges with limitations in executive functioning in particular. So as a consequence, typical antidepressant medications like SSRIs may not be as effective in older adults as in younger adults. Still worth trying, but not as effective, unfortunately. However, we are blessed with still very effective treatments that unfortunately are underutilized. In particular, I'm talking about ECT, or electroconvulsive therapy, which remains the gold standard treatment for depression, particularly in older adults. The challenge is that there are multiple barriers to an older adult getting ECT. The first is the pronounced stigma that many people in the general population feel about ECT. Most people in the general adult population see ECT as a treatment that Jack Nicholson got in One Flew Over the Cuckoo's Nest, which is a great movie, but it really doesn't portray ECT in an accurate light at all. And the fact remains that, again, it's effective in particular for older adults with the severest forms of depression. The other challenge is that ECT, frankly, is not easily obtained in wide swaths of the country. There's areas in the country where ECT just isn't available at all in the entire state. We in California are somewhat blessed by more ECT services than most states, but even here, there are entire areas of the state where you just can't get ECT without traveling hours out of your way. So it's a particular challenge. And therapy remains very effective, even in the face of significant cognitive changes. There's an old adage that you can't teach an old dog new tricks. That's false, because the reality is that therapy is very effective. You may need to focus more on the behavioral interventions and the cognitive interventions, but still very effective. So there are some novel treatments, and this is going to be my one plug for Stanford. Stanford does have a relatively unique variant of the standard TMS protocol, which gives a more robust simulation, not just once a day, but 10 times a day for 5 days sequentially, as compared to the 6 weeks that is standard. And the data up till now shows that there's about an 80% of these subjects have resolution in suicidality and a significant reduction in depression to remission. So pretty encouraging. That's comparable to ECT. The caveat is that TMS, even this particular variant, hasn't been demonstrated to be effective for the more severe forms of depression, namely catatonic depression and psychotic depression. We've all heard of or know about ketamine as a potential avenue of treatment. It's still being investigated, of course, but it's certainly promising, in particular for acute resolution in suicidality. The challenge is that it really hasn't been studied in depth in older adults. The one site that's doing a study in Yale, Rachel Ross, has thus far had limited evidence of benefit into the older adult population. But the jury's still out about that, but still promising, of course. And finally, of course, there's increased interest in psychedelics as an avenue of treatment. And there too, the jury's still out. It's still being investigated in the general adult population, let alone the older adult population. So we still don't know much about its efficacy or safety in this vulnerable population. So, you know, the 800-pound gorilla in the healthcare room is dementia. And why would I talk about dementia when this is a psychiatric talk? It's tough because, of course, dementia, based on CMS guidelines, is a medical diagnosis. And yet, from the very beginning, dementia has shown clear psychiatric and behavioral consequences. Alzheimer's sentinel case of dementia, August D., showed significant psychiatric symptoms on her initial presentation of hallucinations, delusions, and this very colorful description of her screaming horribly for hours and hours, having strong feelings of jealousy toward her husband. I mean, that sounds like a psychiatric issue, but I'm a psychiatrist, of course. The challenge, though, is that it's hard to manage any of these kinds of behaviors in any place but a psychiatric institution. And you know, these are the kinds of patients who do horribly on a med-surg floor, where they're, you know, with other complicated medical cases, and it's just not an optimal situation, an optimal environment for managing behavioral issues. And the reality is that behavioral issues are common throughout the course of dementia. They're actually present even before the diagnosis of dementia is made. Well over 2 or 3 years before the diagnosis is made, people are struggling with depression, significant sleep disturbance, anxiety, and following the actual diagnosis, behavioral issues are endemic. About 80% have trouble with agitation, aggression, there's significant mood instability. So when we're talking about dementia, we really should consider it a psychiatric issue. The challenge is that the CMS code doesn't allow many of these patients to receive appropriate care in a psychiatric facility because of the restrictions on the mental health code. So for example, someone with these behavioral issues wouldn't be able to be placed on a 5150 without a lot of sort of contortions in the diagnosis itself. It's possible, but any public attorney worth their salt, if they looked at the chart, would rightly point out that the behavioral issues are driven by dementia, not depression or psychosis. And consequently, they wouldn't be appropriate for hospitalization in many of the locked facilities that would be appropriate for their care. And the consequences for the families and patients, of course, are huge. There's significant functional impairment associated with behavioral issues. They have worse quality of life. There's significant financial burdens associated with their care. I don't know how much care costs in Orange County or San Diego, but in the Bay Area, placement in a memory care facility runs about $10,000 a month. And I don't know how much you guys make, but I certainly couldn't afford that kind of cost, at least with my salary. So something that we have to think about. And the reality is that there are, you know, presently our society isn't set up, isn't prepared to address this growing demand. Because again, the baby boomers are getting older. So how do we best manage these behavioral issues? Well, it's ideally addressed in a multidisciplinary fashion with you know, a combined team of internists and psychiatrists. Because the reality is that dementia doesn't present alone. Invariably, someone with dementia has often significant medical comorbidities that complicate their presentation. There are several studies that we did at UCSD when I was there that showed that about a third of people who came in with purely psychiatric issues actually had medical complications that were the proximate drivers of their behavioral change. Even things as simple as constipation, urinary retention, or undiagnosed or untreated pain were often you know, present and when treated, ameliorated their behavioral symptoms. And the reality is that if unaddressed, these medical complications are likely to significantly increase lengths of stay and certainly lead to significant medical complications if not addressed. Another area of interest has been geriatric emergency departments, and this is something that really has been sadly overlooked for many years. I don't know how many people have had the pleasure of being in an emergency room lately, but it's not an environment designed to provide comfort or reduce confusion. There are lights on at all hours of the day. There's significant noise pollution. It's an environment that's almost designed to increase delirium in older adults in particular. And we know that by doing as simple things as changing the light stimulation, having a diurnal pattern to the lights, or trying to reduce the noise pollution again, can significantly reduce risk of increased confusion, increased delirium, and save the system potentially a significant amount. But the other part of geriatric emergency services that are equally important are the staff. I mean, having faculty or people who can diagnose polypharmacy, do a cognitive evaluation, and as importantly, connect patients to community services. That's really where there's a dearth of service, dearth of help, because it's the people that ultimately make the biggest difference, of course, in these kinds of issues. So I've already touched on some of these hurdles. I mean, the big challenge really is having a team of people who can coordinate the comprehensive care that's necessary for caring for an older adult with dementia in particular. And it's going to be an ongoing challenge. But the dilemma is that there are so many different services that are involved, so many different players involved, that having one captain who can run the ship is crucial. And there are different models that can be helpful. Primary care may often take the lead in this, but primary care already is overstretched, as we know, and adding this additional responsibility to most primary care clinicians is, I think, asking quite a bit. There are, again, models that may be helpful. Jürgen Unister up at UW has pioneered, in particular, a collaborative care model that may be a model for service down the road, but paying for that is also daunting. At least in Stanford, we've been trying to get that model off the ground, and the payer model that is available just hasn't made it viable. So I'm curious to hear how other services, other systems have worked around that conundrum. Other reality is that there is a dearth of geriatricians in the country. In particular, there's only 1,700 or so geriatric psychiatrists in the US at present. And that number is not likely to increase in the near future. The pipeline just isn't there. The reality is that asking a psychiatry resident to spend another year in training to get a pay cut is not viable. I mean, even the most dedicated of residents swallows when they realize that they're sacrificing in order to do this kind of work. So it's a challenge. And it's not just physicians, of course, it's also nurses, it's also social workers. There's a whole team of people who are necessary to provide optimal care for this very vulnerable and necessary population. So, it's something that we have to work on now, because the reality is that the future is here now. This is something that we have to deal with at present. It's not 10 years down the road. And again, the reality is also that I'm not sure what the community resources are to provide for these needs. It's great to hear of the work that Marshall's been doing. I'm curious about other avenues that this work could continue on. But the reality, again, is presently it's either family who has to sacrifice for providing care to these patients, or someone has to spend, again, something like $5,000 to $10,000 a month, or the patient has to spend down to qualify for Medi-Cal. And of course, that's also a very daunting step to take. So the dilemma is that we need to do this as a society. And we as a society have to make some real choices about what direction we want our country to take. And ultimately, I have to admit, I'm a little selfish, because I want this problem to be solved before I turn 65, because that age is coming sooner than I expected.
Thank you, and that leaves us just about a half an hour for questions. I have some of my own, but I'd love to have you all raise your hand. We do have roving microphones, and while we're waiting for someone to have the courage to be the first to ask the question, I will also plug Stanford University right now, even though I'm a Cal grad, because we actually have Dr. Nolan Williams from the Stanford Brain Stimulation Lab, who will be coming to the California Hospital Association's Behavioral Health Symposium in Riverside, December 5th and 6th. So my own plug there, that we'll hear actually more about their work in the brain stimulation area to treat really difficult to treat depression. Any questions from the audience?
So we have time for a couple of questions, because I know we're scheduled at a break here shortly.
So a question for Dr. Kim. The rest of medicine is looking more and more seriously at team-based care, looking more and more at moving outside of clinical settings and ways in which to engage community health workers, promotores, others. How are you thinking in those terms as it relates to the future, given what you've described are the realities of the pipeline? What are ways in which to take a much more team-based approach to this?
Yeah, the great question. And the reality is that at present and looking in the future, there aren't going to be enough geropsychiatrists or geriatricians to provide care to the growing older adult population. Ultimately, you're absolutely right. The only way this is going to work is for geriatricians to partner with primary care in particular to provide care for these folks. And ultimately, this integrated care model, collaborative care model, is the wave of the future. And the idea is that geriatricians, psychiatrists would be embedded in a primary care setting, either in person or potentially remotely. And we would consult with the primary care folks and potentially see patients who are really complicated in person. The challenge that at least I've been facing in trying to get this model off the ground is the payer model. And the question is, who's paying for our time in the clinic? Because if you're not seeing the patient directly, then you don't get paid. And there are, I know ways of getting around this, but thus far we haven't had the institutional support or buy-in to make that model a reality.
We have another question over here.
This question is for Marshall. Really interesting with this hub and spoke model. Did you actually see a decrease to your transports to the emergency departments that was statistically significant for your area? And have you seen an impact to your times and metrics related to that?
So not yet in the way that we have been hoping for, and that's largely due to the bit that I didn't go in depth on, but just flashed on the screen around the contracting structure. And so we've just readjusted the contracting structure so that we can have more control over the front door of that facility. And so that's about 30 days old. And already we have the mobile program now connecting with the local hospitals and folks that are medically cleared and appropriate for that facility, pulling them out of the hospital. And so we expect in a year's time we'll have some really good data about that. But it was a learning point for us on the operating model of that campus over this first year. What we do know is that law enforcement and EMS are dropping off by the many hundreds. And so we're about to do a study with UCI to look at what is that positive impact on the ERs. But we're still early in the data.
Any other last questions before we head to break?
Thank you so much. Thank you for the great information and the presentation. My name is Colleen Lafuente. I work for the California Community Colleges for the nursing and allied health programs. And my question, and more like a comment, is if you have addressed the issues and challenges in terms of the career pathways at workforce development, because I feel that in every presentation we hear, we're talking about the shortages of workers. And in our community colleges, we're facing a challenge that we can only train enough students to come into the workplace based on the number of clinical placements we get. and the hospitals have been completely stressed out, and I acknowledge that, and I'm very grateful to all the hospitals that provide these opportunities for our students. But I also want you to be aware, and this is a big challenge that needs to be addressed, that our clinical placements have been reduced. So instead of having rotations that take 10 students, they're only taking 4 to 5 students. And what that means is that we as community colleges are not able to welcome students into the nursing or behavioral health courses. So that's kind of like a common challenge. And also ask you as experts, how do you foresee us working together in collaboration? That was another aspect that was brought up, to work in collaboration with other communities. So we are here open to work on that collaboration, and thank you for the information you shared this morning.
We are due for a break right now, and I know that many of us will be sticking around, so let's give our panel a round of applause, please.